Welcome to the Future of Dermatology podcast. I'm your host, Dr. Farah Kamangar, board-certified dermatologist. Along with being a dermatologist and the host of this podcast, I am also the president of the San Francisco Dermatological Society, which is composed of dermatologists who practice in the San Francisco Bay Area. Every year, we hold our annual SF Derm meeting, and this year we gathered our guests at the Ritz-Carlton in Half Moon Bay. From engaging sessions to incredible food and even a round of golf, SF Derm 2024 was a huge success. Continue listening to hear thought-provoking conversations from our incredible dermatologists who presented on matters that answer your dermatology questions, align with our goals, and provide insight to the future of dermatology. Dr. Paradi Mirmirani completed residencies in both internal medicine and dermatology, and also a hair research fellowship at UCSF. And she currently works at the Permanente Medical Group in Northern California, where she serves as the Assistant Medical Director for the Regional Clinical Trials Program, as well as the Regional Director for Hair Disorders and Dermatology Research. In addition to being an active clinician, researcher, teacher, she regularly presents at national and international conferences on various hair topics. So we're so lucky to have you here. Thank you, Dr. Mirmirani.
Thank you so much, Farah, for that introduction, and thank you so much for an incredible meeting. I mean, weather aside, I think this meeting has just really been the bomb. Farah is such a fantastic organizer, and I've been to some pretty cool meetings, but I haven't ever, if you guys missed it yesterday, we had green juice shots as part of our snacks. So, very California, gotta love it. And of course, always wonderful to connect with friends and colleagues here. I'm here to talk about my favorite topic, which is hair loss updates. I do have some disclosures, but bottom line, I've been involved with all the clinical trials with the JAK inhibitors and alopecia areata, so I'll talk about that a little bit. But mostly what I would like to do today is to just give you some practical tips so that you can go back to your clinic and really make a big impact to your patients with hair loss and with alopecia areata. In particular, what I like to do with these update talks is to think about some of the common questions that come up from all of my colleagues, from when I'm teaching the residents, and then put that, I do journal scans as well and write commentary for practice updates. So to kind of take the top few and kind of give you my take on things. Let's talk about our next topic here now, hair miniaturization. If you're not already using your dermatoscope for your hair patients, examining your patients with the dermatoscope, please go back and pull out that dermatoscope and just get accustomed, even with the patients without hair loss. Take a look at their scalp so you know what normal looks like. There's always a little bit of scale, there shouldn't be much redness. Look for miniaturization. Be a miniaturization detective, because you really want to see if there's miniaturization. We now have a really good tool. We've always had a good tool, but with low-dose oral minoxidil, it makes treatment for these patients much more effective. So I think we've always thought of miniaturization as being the most important factor or kind of hallmark of androgenetic alopecia. But miniaturization also, you can find it in other places. With alopecia areata, you can see it. With traction alopecia, you can see it. You may also see it with scarring alopecias or with telogen effluvium. There may be underlying androgenetic alopecia, but who cares? As long as there's miniaturization, we can treat it. So look for miniaturization and treat it aggressively. Patients will be happy. And I've kind of, with the residents I tell them I've got my triad of treatment. You treat inflammation, you treat miniaturization, and remove, and healthy hair, kind of remove any triggers. If you follow those three principles, then your patients will end up with, you'll end up with happy patients with hair loss, no matter what kind they have. Wanted to give you an update. I think most people feel comfortable using low-dose oral minoxidil, but there's still kind of a lot of questions, kind of like the top questions for JAK inhibitors that I went through. Jenny Fu, Ingrid Roseborough, and I all worked together in the Bay Area, and we realized that we're getting a lot of questions about when do you start it, how much do you go up, do you monitor? And we thought, wouldn't it be great if all the experts came together to answer those questions, those common questions? And I think there's a real need to talk about monitoring for low-dose oral minoxidil. So Jenny really spearheaded this and put together this consensus of experts. We got folks from around the world. Super exciting. Our poster that we submitted at the AED ended up being a 4th place winner, which was great for our fabulous student, Matt, who presented that. Again, I think speaks for the fact that people are really looking for answering these questions. So top questions, who do you use it for? But people felt comfortable using it for everybody, for kids and adults. We didn't get to consensus for ages 6 to 12, but 12 and above, everybody felt very comfortable using it. What do you use it for? Like just as I mentioned before, the experts felt that it was fine to use it for just about everything. So whether it's what you typically think of for miniaturization, androgenetic alopecia, age-related hair thinning, or alopecia areata, telogen effluvium, traction, scarring alopecias even. Maybe there's a primary role for minoxidil in some of these, maybe it's a supportive role for some of these, but yeah, go ahead and use it. I didn't read that part. Starting doses. Okay. Yeah. So what were the typical starting doses for patients? So where do you start? And we went back and forth a little bit, but for the most part, the experts felt comfortable in women starting at a dose of 1.25 and going up to 5, and then in men starting at 2.5 and going up to 5. The gender and age may make a little bit difference in terms of how you start the medication, but that's pretty much what I do. Is I start in women 1.25, so that's half a pill, and men I start with a full pill, mainly because of the concern around hirsutism. So are there any situations where you don't want to start minoxidil? I think that's the worry that we all have. I think, again, for the most part, we've gotten comfortable. Yes, so if the absolute contraindications that are in the package insert, history of pericarditis, CHF, pheochromocytoma, pregnancy, are absolute no's, but using caution in somebody who's had renal impairment or any cardiac disease. And I think when I first started doing a lot of low-dose oral minoxidil, I'd pick up the phone and ask the cardiologist, and they were like, no worries. At that dose, sure, no problem. And I think as we've continued to use it, for the most part, there are very few contraindications with low-dose oral minoxidil. Do you need to test? Do you need to do blood pressure monitoring? And the answer is no. And we had a cardiologist who worked with us. No testing needed unless there's a precaution identified. No need to monitor the blood pressure because it's an antihypertensive. The medication has 2 effects. There's a vasodilatory effect and there's a fluid retention effect. So you can tell the patient just based on clinical findings. So when you start taking this medication, if you have lightheadedness, fast heartbeat, then let me know or stop the medication. So that's the vasodilatory effect. If you have leg swelling, which usually happens a little bit later, then that's minoxidil, and you can either lower the dose or add a medication or stop the medication, stop the patient. There are 2 reports of pericardial effusion. Both of those patients had leg swelling and facial swelling before that happened. So I think if you tell patients leg swelling, stop the medication, you're safe. If you use minoxidil, you need to know how to deal with the hirsutism because it is there, whether it's topical or oral. Potentially a little bit more with oral, but again, what do you do if the patient is doing great with minoxidil, but they can't stand the excess facial hair? Decrease the minoxidil dose, make it a quarter pill, add spironolactone, it's a great option. Add finasteride, it works well for hair. I prefer finasteride over spironolactone because it's better hair growth. Depilatory is lasers, of course, but often I will do a combination of minoxidil plus spironolactone if they're desirous of pregnancy, minoxidil plus finasteride if they're no longer desirous of pregnancy. So right when you were getting excited about low-dose oral minoxidil comes the studies head-to-head, where we're looking at topical minoxidil. This was topical minoxidil solution, so I generally use the foam. But still, good to know that 1.25 milligrams was non-inferior to 5% minoxidil solution. So that's another question I get frequently. Do you start with oral? Do you still use topical? I use a ton of topical. I always start with topical. I talk about topical. So that's certainly an option still for patients. Same situation with men, similar study that was done, minoxidil 5%. Placebo versus minoxidil placebo, again, non-inferior. Moving on to my last topic, which is scarring alopecia. I've gotten quite a few, just talking to people in the room here. I think this is an area where, are we really seeing more of it? Yes. What's going on? I really feel strongly there's probably an environmental component to this, whether that's the whole story, probably not. There's probably many factors that contribute to scarring alopecia. But the environmental factor is something we can modify. It's something we can change. I can't change genetics. I can't change hormones necessarily or very well, but we can change the environmental impact. And this was another report from the World Congress, again, looking at cell culture, at hair follicle cell culture. So this was in vitro, but still very interesting, looking at linalool, which is a common synthetic fragrance. I'm sure all the patch test folks here hate this because it's in everything and it causes a lot of problems. So when there was linalool exposure in cell culture of healthy hair follicles, bad things happened. Decreased K15 epithelial stem cells, other markers that were associated with loss of immune privilege. So the hair follicle is not happy. Now, are these, in patients, patients have inflamed scalp. When you put stuff on, do they become sensitized? I don't know. But again, it's something that we can change. There was a recent study looking at patch testing, again, increased risk factors in patients with scarring alopecias. So I'm pretty militant about telling patients to avoid. No longer use anything with fragrance, no longer use any other potential triggers, including chemical sunscreen. So this is a patient, again, frontal fibrosing alopecia. I was really struggling to get her under control. No matter what I did, it seemed like she still came back. Her scalp was red, inflamed. I was trying to patch test her. It was during the pandemic. I had told her to stop all the chemical sunscreens and fragrances. I did. And then it was like this hallelujah moment. I said, "Are you sure you've stopped everything? What do you bring your stuff in?" And turns out she had a moisturizer with chemical sunscreen. She's like, "Well, you said sunscreen, not moisturizer." It's like, okay, stop this one, and then we'll get you patch tested. She came back and she was a new person. My scalp feels 100% better. So once we really discontinued everything. So these days, I just straight off the bat, first time I see patients, stop fragrance, use this skincare line that is kind of free and clear, and avoid anything that's fragranced. And if you think about it, just mechanistically, the sebaceous gland as the trigger for these conditions. The sebaceous gland is a reservoir for all sorts of toxins. It's highly active metabolically. There's a lot of things that can cause damage. So these are all the various things that can potentially cause problems, and then loss of immune privilege and inflammation. Other things that may factor in: genetics, hormones, environment. This was my first patient that really got me thinking about sunscreen use. She was a swimmer from a very young age. She would put sunscreen on like this on her face, and then she would finish off by putting it down her center part. And you can see here that she has no eyebrows. Her hairline used to be here, and this is where she put the sunscreen on, center part. She stopped using sunscreens. I think she stopped everything. And she came to me and she said, "Dr. Mirmirani, please tell the world that once I stopped the sunscreen, the inflammation, the redness, everything, the hair loss went away. So modifiable factors, just get rid of them. Thank you.
Thank you for listening to the Future of Dermatology podcast. Remember to hit that subscribe button and share the podcast with your friends. The more you share and subscribe, the more we'll be able to grow and share our dermatology knowledge. If you have burning dermatology questions, feel free to leave them in the comment below, and we would love to address them in a future episode. And please note that this podcast is not intended to substitute for medical advice from your doctor.